everyone. I think we're going to get started here. So welcome to Psychology Education Day here at University Health Network. For those who don't know me, I'm Dr. Martha McKay, Discipline Head for Psychology here at UHN. And I'd like to begin with acknowledging the sacred land on which University Health Network operates. For thousands of years, it has been the traditional territory of the Huron-Wendat, the Haudenosaunee, and most recently, the Mississaugas of the Credit River. This territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Haudenosaunee Confederacy and the Confederacy of the Ojibwe and allied nations to peacefully share and care for the resources around the Great Lakes. Today, the meeting place of Toronto is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work and learn on this territory. Thank you all for joining us today on this snowy day, and happy Psychology Month. Our psychology team at UHN continues to provide essential and valued mental health care for our patients through assessments, neuropsychological assessments, interventions, behavioral and rehab supports, and initiatives across UHN. I hear time and time again that we are valued team members of our healthcare teams here at UHN, and we continue to be leaders, innovators in practice, research and development, as seen through the numerous initiatives, appointments, publications, awards, receipt of funding that will no doubt inform and improve best practices. I hope that you've all taken a moment at some point during Psychology Month to celebrate all your accomplishments. So before we move into the presentations for today, we'd like to take a few moments to acknowledge a member of our group. Given that this event occurs once per year, we could not pass up the opportunity to acknowledge with much gratitude a pillar of our profession, Dr. Mary Pat McAndrews. There she is. So over the next little while, she will be retiring from her clinical roles to focus on her research activities. And as she's been a powerful voice and a champion of psychology, we would like to take a few moments to acknowledge her many contributions to the practice of psychology here at UHN. Now, I'm a co-author on this. I'm just the one at the podium, so please know that this is coming from your many friends and colleagues across psychology at UHN. Dr. McAndrews exemplifies a model of practice for psychology that includes highest standards for evidence-based practice that improves patient care, education, both within psychology and interprofessionally, mentorship for many learners and colleagues across the organization, and enhancement of the science behind our clinical practice. Her leadership and practice of psychology and neuropsychology has taken many roles over the years, including former psychology department head, psychology practice lead, chair of psychology council, and discipline head for psychology. And not to mention director of the neuropsychology clinic, one and only of its kind, and neuropsychologist and cognitive neuroscientist. She is well known at many leadership tables across the organization and has always been an advocate for our profession. She has modeled for UHN just how essential, versatile, and innovative our profession is for clinical practice and patient care. We can't imagine the battle she's had to fight over the years, but because of her voice and championship of psychology, we're valued team members across UHN. Dr. McAndrews has played a vital role in the establishment of many of our psychology education initiatives, including the Psychology Education Training Committee, Psychology Education Day, and psychology resident roles. She has supervised many learners, taught many courses, and fostered the careers of many within our profession. In addition, she has mentored countless students, fellows, residents, colleagues, generously sharing her knowledge and time. And trainees have shared that they feel as though they can see their pathway to becoming an excellent clinician after working with her by infusing research into their practice. Dr. McAndrews has enhanced the science behind evidence-based practice and improved the care for individuals with epilepsy. Her ability to integrate research outcomes into clinical practice has had a significant impact on improving patient outcomes. She's developed fMRI procedures to determine language, letterization in epilepsy, and motor mapping. She's expanded this practice to interoperative language mapping and other populations beyond epilepsy, such as those with surgical tumors. She's also been an advocate for the water procedure to help determine safety for epilepsy surgery and these extensions of neuropsychology into imaging and surgical procedures. She's created a pathway for psychologists to carve out their area in the current academic hospital setting. And in all these endeavors, she's embodied the scientist practitioner model to deliver the best quality patient care by examining the empirical basis for offering it. We are very glad that you're not going far and you're not disappearing, and this is by no means a goodbye. But on behalf of UHN Psychology, we wish you success in your research activities, and we thank you for all your foundational contributions to the practice of psychology. So however you can, please join me in thanking Dr. Mary Pat McAndrews. You can use reactions and
thank you all. Thank you, Martha, and all my psychology colleagues. Very much appreciate it.
Thank you, Mary Pat.
But I'm not going away.
Not going away. This is not a goodbye. Okay. All right. Our title for today's event is Trauma-Informed Mental Health Care. As we know, many are impacted by trauma, and the individuals that we provide care for through many of our services here at UHN may have experienced some form of trauma. It's certainly something I address almost on a daily basis in my clinical practice at Toronto Rehab. Trauma-informed care is an important part of our practice, and we are very fortunate today to have 3 accomplished speakers who will be sharing their work with us that will help continue to inform and improve our practice. I'd like to thank our Psychology Education and Training Committee, Doctors Leslie Rattan, Susan Winnup, Marta Chuka, and Danielle McDonald for putting together today's wonderful event, and to Christian Peterson for all the tech support behind the scenes. On today's agenda, we have 3 presentations, and we'll have a brief question and answer period immediately following each of the presentations, and then we'll have a panel at the end of the event for more questions. And to answer your questions, please use the Q&A function at the bottom of your screen. All right. I am thrilled to introduce our first presenter. Dr. Catherine Trache is a psychologist and clinical program lead in the Eating Disorder Program at UHN, the Provincial Clinical Lead for Eating Disorders with Mental Health and Addictions Center for Excellence at Ontario Health, assistant professor in the Department of Psychiatry at the University of Toronto, where she is a current recipient of an Academic Scholar Award to support her work in the area of integrated treatment for individuals with eating disorders and post-traumatic stress disorder. Dr. Trache is known internationally for developing and testing the first integrated treatment protocol for eating disorders and PTSD, and has authored a psychoeducation workbook entitled Cognitive Behavioral Tools to Help You Move Forward in Recovering from Your Eating Disorder and Trauma that has been disseminated across North America. With the onset of the pandemic, she also collaborated with colleagues to develop Restore, a transdiagnostic internet-delivered intervention for symptoms of post-traumatic stress disorder, anxiety, depression associated with exposure to traumatic and extremely stressful events related to COVID-19. She's going to talk to us today about trauma, PTSD, and trauma-informed mental health care. Please welcome Dr. Catherine Trache.
Thanks so much, Martha, for that lovely introduction. Just going to take a second here to share my screen. Okay, looks like everybody can see that. So I am going to talk to you today, as Martha said, about trauma, post-traumatic stress disorder, and trauma-informed mental health care. And I'm very aware that I only have a short 30 minutes today in which to do that. And this is something I think I could talk to you all about for hours. So what I want to do today is focus on some key information that I think is really foundational to providing good trauma-competent care. So that's what is trauma and PTSD? How are trauma-related symptoms maintained or what keeps them going? How do people get better or recover from trauma and PTSD? And importantly, how is this information important in providing trauma-competent mental health care? And then finally, some principles of trauma-competent care. So there are a number of challenges that can arise for those with trauma-related symptoms when they're engaging with our healthcare system. Some of these things are difficulty with trusting the treatment team, trouble with dissociation symptoms, trouble with somatic symptoms, experiencing an increase in distress due to exposure to trauma reminders in the healthcare system and in the treatment context. And as people are engaging in mental health treatments, for instance, substance use treatment, and decreasing problematic behaviors like substance use, there's less reliance on maladaptive coping behaviors, and there can be more distress related to trauma. Also, engaging with the healthcare system and mental health care often involves giving up some degree of control, for instance, being admitted to an inpatient unit, or even engaging with a treatment protocol, and that can be very challenging for people with trauma-related symptoms, and we'll talk about why as we go. Ultimately, the concern is that people who have trauma-related symptoms might be susceptible to ending treatment early and poor treatment outcomes related to their trauma. I wanted to start by just talking a little bit about terms, and I know that can seem boring, but it's actually really important to our understanding of trauma-competent care. So when I talk about a traumatic event, I'm talking about an event that involved exposure to actual or threatened death, serious injury, or sexual violence, either through having directly experienced the event, witnessing the event happening to someone else, or learning about the event happening to someone that you're close to. This also includes traumatic event exposure in first responders in the course of their work. So these are some examples of things that would be considered traumatic events. I won't go through that list, but just to give you an idea of what those events are, and by no means is that list exhaustive. I wanted to note there are other extremely stressful or adverse events that people experience, like infidelity, divorce, death, natural death of a loved one, that are very stressful, but that would not meet that definition of a traumatic event. And so we see these events, although there can be some similarities in how people respond to them, they are fundamentally different. It's really important for us to know that trauma exposure is common. I think it's our human nature to want to think that trauma is actually a rare event. Unfortunately, that's not the case. Most people will experience a traumatic event in their lifetime. In North America, 3/4 to 90% of people will experience a traumatic event. Exposure to traumatic events is higher in lower income countries. And we also tend to think that exposure to multiple traumas is rare. In fact, most people will be exposed to multiple traumatic events in their lifetime. About half of people who have a traumatic event are victims of direct interpersonal violence, and that's important. Some things we'll talk about in a minute. Post-traumatic stress disorder. So it's important that we understand what PTSD is. So in order to have PTSD, you have to have been exposed to a traumatic event, but it's much more than just exposure to the event. So PTSD involves experiencing what we call intrusion symptoms. So that's intrusive memories, nightmares, flashbacks about what happened. Avoiding things that remind the person of the trauma. Changes in how people are thinking and how people are feeling associated with the trauma. So this is often an increase in negative emotion and decrease in positive emotion, and thinking things like blaming oneself for what happened. And then we also see changes in arousal and reactivity. So people are hyper aroused and reactive associated with the traumatic event. So in contrast to trauma exposure, which is very common, PTSD is much less common. So you can see here that prevalence is about 6 to 9% over the lifetime in North America. Prevalence of PTSD does increase with the number of traumas that someone is exposed to, and rates tend to be higher in women and people who've exposed those interpersonal traumas like rape, assault that I mentioned before, are more likely to have PTSD. So we know that the great majority of people will be exposed to trauma, but only a small number go on to have PTSD. So that there's an important question that follows from that, which is why, how? How does someone recover from a traumatic experience? It seems that most people don't go on to have PTSD. I want to share a little bit of data that I think is important. I know there's a lot on this slide, but this data is really important. So on this slide is data from 3 different studies. So each of the colors, the teal, the pink, and the yellow represent different studies. On the left side, you'll see data related to rape, and on the right side, assault. So these are folks who were exposed to trauma and then were followed in the immediate aftermath up to 12 weeks. And what you see on the y-axis is the percentage of the people who met criteria for PTSD in the aftermath of the trauma. So if we look at the left side, the data for rape, in the immediate aftermath of a rape, over 90%, almost everyone meets the full criteria for PTSD. There is a duration criteria for PTSD of being symptomatic for 4 weeks. So setting that aside, almost everyone meets the criteria. If we look at the data on the right-hand side for assault, we can see in the immediate aftermath, over 70% of people experience full criteria for PTSD. So less, but still quite significant number of people meeting criteria for PTSD. The other thing that's really important from this data is what we can see is that over time, from the immediate aftermath of the trauma to 12 weeks out, there's a pattern of decreased symptoms. And that happens for both rape and assault. So what appears to be happening is that people appear to be naturally recovering from the trauma, naturally recovering from the PTSD symptoms. These are all folks who haven't had intervention in the aftermath of trauma. So what we know about recovery from trauma exposure, PTSD symptoms are normal in the aftermath of trauma. When a traumatic event is severe, almost everyone will experience PTSD symptoms. Most people will recover naturally from the trauma that occurred. So what this means is that PTSD is a problem of impeded recovery. And this is really unique to PTSD. We don't see this in any other areas of mental health. So in the case of PTSD, we know what the cause of PTSD is. The cause is the traumatic event. The question is, what keeps PTSD going? What keeps the symptoms, the trauma-related symptoms that are normal in the aftermath of trauma going and prevents people from getting better? So there's a lot going on this slide, but what the main point to see, so these are some of the kind of core clusters of PTSD symptoms. So those intrusion symptoms, the flashbacks, nightmares, unwanted images and memories of what happened, your hyperarousal and reactivity, like trouble concentrating, exaggerated startle response, being very irritable, and then changes in emotion and cognition. So lots of negative emotion like guilt and shame, and a decrease in positive emotion. And also changes in thinking like blaming oneself or someone else not to blame for what happened, forgetting about what happened, and having negative beliefs about self, others, in the world. So when someone has PTSD, these collections of symptoms are triggering one another and feeding into one another. So what happens in the process of natural recovery? So how we understand natural recovery is that when someone has an intrusion symptom, so when they have a nightmare, a flashback, an intrusive memory about what happened, they engage in an approach process. They feel their feelings about what happened. The hyperarousal runs its course, and they start to think through what happened with themselves and also with support of others. And through that process, the natural emotions like anxiety and fear, sadness, and the arousal dissipate. And as those emotions and arousal dissipate, the reality of what happened is accepted. People work through it, and they shift their problematic thoughts. And people become more open to shifting thoughts like self-blame once the emotion has decreased. So in natural recovery, the intrusions, the arousal, the emotions and cognitions decrease over time, and they no longer trigger each other. In contrast, for those who don't recover naturally, for those who get stuck in PTSD, the intrusion symptoms, the trauma-related distress, leads to escape and avoidance behaviors. So this can be things like avoiding reminders of what happened, pushing thoughts and feelings away, trying to push them out of their mind. But what you'll also notice here is that there's a whole host of other behaviors and mental health symptoms that people might have that can be forms of escape and avoidance. So things like self-injury, thinking about suicide, misusing substances, experiencing somatic symptoms, dissociating, binge eating, purging, all these eating disorder symptoms. So these are all ways that people who've experienced trauma may escape and avoid what happened. It's important for us to recognize that psychological trauma, particularly of an interpersonal nature, is a risk factor for the development of a broad range of mental health problems. There's also evidence suggesting that PTSD in particular is a mechanism linking trauma to psychiatric comorbidity. So this is a model that I like to draw with my patients and clients who are presenting with multiple mental health problems. And this is a model that they actually find quite relieving in that sometimes they feel overwhelmed by the number of problems that they're facing. And when we take a look at it this way, and they realize that the trauma-related symptoms and PTSD that they're experiencing is at the heart of the problem, they can start to see a way forward that if we address the trauma, we might be able to make headway in the challenges they're facing. I do want to highlight that unfortunately, in many ways, these avoidance behaviors can be relatively successful. It can be that these behaviors that people are engaging in, like eating disorder behaviors, substance use, self-injury, can be quite effective at distracting from, blocking out, or numbing trauma-related thoughts, feelings, and memories, and decreasing hyperarousal symptoms. And that's very reinforcing. And in these cases, we often see that PTSD symptoms are subthreshold. So people might not meet full criteria for PTSD. Sometimes PTSD might even be absent. We've seen that happen as well. Certainly in our eating disorder program, where we screen everyone for PTSD, we've seen cases where people have a few symptoms that really increase over the course of eating disorder treatment, sometimes no symptoms, and then very severe PTSD by the end of treatment. So that speaks to the last point that I was mentioning there, that PTSD symptoms are likely to increase as avoidance behaviors are stopped. And this is really relevant to those of us providing mental health care, where people are working on reducing or stopping problematic behaviors like substance use, eating disorder behaviors, self-injury, suicidality. So factors that might impede a natural recovery from trauma. Certainly we're talking a lot about avoidance. Avoidance is really important. Also a lack of social support. We understand social support to be very important to recovering from trauma. And then also pre-existing negative beliefs. So people who have negative beliefs before a trauma happens, like the world is a dangerous place, I deserve to suffer, people can't be trusted. These things put people at risk for getting stuck in the recovery process. So how do we help people get on the path to recovery? Really important for us to understand that this does require approach rather than avoiding. Avoiding keeps people stuck. When we go along with avoidance and accommodate PTSD in our patients and clients, we reinforce it and they stay stuck. The way forward is to engage with them about their trauma symptoms, about their avoidance, and the potential connection to their mental health problems. And I really want to stress, even if we aren't providing trauma-focused treatment, we can help people to move forward toward recovery through good trauma-competent care. There are many different definitions and models of trauma-informed care. There are three common elements, though. The first is realizing the prevalence of trauma and recognizing how trauma-related symptoms affect patients and also care providers. And then the third one, respond by putting knowledge into practice, is really characteristics of trauma competent care. So we've talked a lot about trauma informed care over time, and you might have noticed language shifting to trauma competent care. And this really connects to number 3. So saying it's not good enough for us to just be informed, but we actually need to do. So we need to put our knowledge into practice. So I'm going to share some principles of trauma competent care with you. So this first set are about the understanding part. So understanding that the symptoms we may be seeing in patients may be trauma related. So if we're seeing substance use, if we're seeing eating disorder behaviors, if we're seeing suicidality, it's possible that those are trauma related symptoms. It's important for us to understand that for people who've had an interpersonal trauma, this often leads to disruptions in trust, which is very relevant when interacting with the healthcare system, particularly mental health care. It's important for us to understand the person in their own context. In terms of the approach that we take or the clinical stance, being non-judgmental is essential, ensuring safety and stabilization, which I'm going to talk more about in a minute. And then in terms of what we need to do, how we respond, it's really important to provide education about trauma reactions, and I've bolded here, and recovery. I think this is often a piece that's missing when I hear about what the trauma-informed care that people are providing. Essential to take a strengths-based approach. So we want to teach skills, we want to build social supports and provide opportunities in mental health care for people to rebuild a positive sense of control, and incredibly important to treat people who've had trauma as capable. Also important to attend to the quality of the therapeutic alliance and to attend to our own clinician self-care. So in the time that I have, I want to focus on some things, some of those principles that I think are tricky, where people sometimes get tripped up. And this is thinking about safety and stabilization and the idea of re-traumatization and what these things mean. So let's talk about creating a safe environment. Safety is always talked about in trauma-informed, trauma-competent care. So first and foremost, all healthcare should be physically safe and free of harassment, discrimination, and abuse. It's also important for us to anticipate that stimuli in the environment and interactions with healthcare may remind someone of a trauma they've experienced, and that we have strategies that we can implement to help people cope with those reminders. Another way that we build safety is to have consistency in our interactions with clients and in our treatment processes, and always following through on what's been planned in sessions or meetings. So if we're saying, in the next session, we're going to do X, Y, and Z, really important to follow through on that. If we're assigning homework or practice, really important to follow through on that. Just wanted to share an example of a tool that we use in our work that helps people to cope with trauma reminders that they might be experiencing in the context of the treatment environment. This comes from the workbook that Martha mentioned that I wrote. So this is a cognitive behavioral tool that really helps people to take a closer look at their reactions that they're having to reminders. And in particular, if you look at the column C, compare, I think the key intervention here is helping people to see that the current reminder situation is different than the original trauma, that it's not happening to them all over again. And our patients find this incredibly helpful in helping them to continue to move forward and not get stuck. If anyone's interested in that workbook, it is written for people with eating disorders. I'm happy to provide it. Just send me an email afterward. Some things to just keep in mind. Creating a safe environment does not mean eliminating all trauma reminders. This is something I often see people trying to do in providing care for people who've had trauma. It also does not mean that we get things right all the time. What's really important is how consistently and forthrightly we handle situations when circumstances provoke feelings of being vulnerable or unsafe. Honest and compassionate communication that conveys a sense of handling the situation together is what generates safety. I want to talk about the concept of stabilization. So what does stabilization mean? So when we're talking about trauma-informed care, we're always hearing about safety and stabilization. So stabilization means getting an individual to a non-crisis level. And what does that mean? Well, basic needs being met, the person's able to function, perform ADLs. They're not at imminent risk of hospitalization. I think where things get tricky is what about cases of chronic suicidality and self-injury? We often see people who are experiencing chronic suicidality and self-injury described as being unstable and needing stabilization. And I think the thing that we need to be aware of is that patients and clients can get stuck in a stabilization phase of mental health care. When we raise the bar too high to access treatment, they can get stuck in always being given stabilization interventions that focus on skills rather than treating their mental health problems. I think we need to recognize that things are never going to be perfect for these folks. So certainly if we've got someone who's actively suicidal and making frequent suicide attempts and at risk of hospitalization, that person isn't stable and that needs to be addressed. But if we've got someone who's chronically suicidal, but is able to not act on those urges and move forward with mental health care, we should do that. If we've got people who are self-injuring, again, I think we need to look at the severity of the self-injury, the frequency of it, and not hold people out of mental health care because they're engaging in these behaviors. The other thing I think that can lead to people getting stuck in the stabilization phase of mental health care is when there's clinician anxiety and fear about providing treatment to people who may be at risk and the potential of destabilizing them. And we'll talk a little bit more about that in a second. I also want to talk about the idea of re-traumatization, which avoiding re-traumatization is often included as a principle of trauma-informed care. So if we look at what re-traumatization is, so the definition is feeling as if the past trauma is reoccurring or as if the treatment experience is as dangerous and unsafe as past traumas. The challenge with this is that it's a feeling. So it's not that the trauma is happening again, it's that the person's feeling like it is. Well, some of the symptoms of PTSD are just that. So in flashbacks, people feel like the trauma is happening all over again. When people are exposed to reminders and they experience emotional and physical reactivity to trauma reminders, it's feeling as though it's happening again. So my take on this term is that it suggests that being reminded about what happened is akin to it happening again. It suggests that intrusion symptoms are dangerous and harmful. And you might remember that earlier I explained that actually intrusions are our cue to approach and feel our feelings and work things through when we've experienced trauma. I think this term encourages avoidance of intrusions, reminders, etc., which can keep people stuck from getting better. And it suggests to clinicians and patients that our role is to prevent distress, which really isn't our role. Our role is to help people work through. Many clinicians are really scared of re-traumatizing patients. And then what we see is people responding by either caretaking or avoiding talking about trauma. So things to watch out for, and these things aren't mutually exclusive, they all sort of overlap, but really watching out for clinician messaging and behavior that reinforces PTSD. I often hear people talking about people who've experienced trauma as being damaged. I noticed in the past year, I noticed this language in a couple of talks on trauma-informed care. This is really unhelpful language for our patients and clients. Messaging that this is too much for you, that people can't handle what happened and they can't handle mental health treatments. And going along with our patients' avoidance. When we collude with their avoidance, we help them stay stuck. Really watching out for treating people who've experienced trauma as being fragile, lowering expectations in treatment, attempting to remove all the trauma reminders, negotiating out key aspects of treatment protocols. And one thing that I've often heard clinicians say and patients have told me that they've been told is you're not ready for whatever sort of treatment, often PTSD treatment as an example. When really we have very little evidence to suggest that people aren't ready for treatment. Most people can engage in these treatments. Also watching out for our own anxieties and fears about trauma-related symptoms. this can be scary for clinicians, and clinicians can want to avoid talking about trauma and related symptoms. And it really gets in the way of good trauma competent care. We can't provide good trauma competent care if we're scared of approaching this ourselves with our clients and patients. So I wanted to highlight that good trauma competent care does involve screening for trauma-related symptoms or PTSD. And this is best done in a standardized way with validated tools. It's really important to understand that most people who've experienced trauma or having trauma-related symptoms, have PTSD, do not present to treatment for those issues, and they don't self-identify as having PTSD. They often don't even recognize that what happened to them as a trauma. So screening is really important. It's also essential. If we are going to screen, we must follow up. So it's not okay to screen and then not follow up. And having some standardized processes for how we do that is really important. Screening, we have found, is a really great starting point for including trauma-related symptoms in care planning and having conversations with our patients about their trauma-related symptoms and how it might relate to their mental health problems in care. Here at the bottom, you'll see a link for the Center for PTSD, where you can see a number of assessment or screening tools for PTSD that are helpful. I wanted to just talk a little bit about starting the conversation. This is often something that's hard for people. How do I bring this up? So the screening is a great way to do that. But when we're approaching screening or conversation about trauma, it's really important to broach the topic gently and to provide a rationale. A rationale for screening and any follow-up we're doing is really important. And keeping in mind that most people are going to be accustomed to avoiding thinking and talking about trauma, and their inclination may be to try and decline talking about it. You might even find that the person says, I have been told by other providers, I don't have to talk about this. This isn't important. This isn't what I'm here for. It's really important to normalize that desire or urge to avoid, and also to reiterate the rationale of why it's important for us to talk about the trauma that happened. I really want to highlight, this doesn't mean getting into the gory details. This doesn't mean people telling their story, but in our experience, it's really important for us to know if there was a trauma, what the nature of that trauma was. Like, for instance, was it a rape? Was it a physical assault? And then to know what symptoms in particular they're experiencing and how that might connect to whatever mental health problems they're presenting with. Just want to highlight how important it is to provide education, and that education go beyond trauma reactions, and PTSD to how people get stuck in the cycle of trauma-related symptoms, and how people get unstuck, how they recover from trauma-related symptoms. And then also really important, and I think often left out of trauma-informed care, is talking to people about PTSD treatments that are known to work, meaning evidence-based PTSD treatments. Please do recommend these treatments to your clients and patients and refer them to them. Jessica, I know, is going to talk to us more about what these treatments are next. In terms of providing education, standardized information is ideal, where all clients or patients are getting the same or similar information, and that information is provided with some clinician guidance. So in our case, we do that with the psychoeducation workbook that I wrote with some clinician guidance. Please do consider the role of trauma-related symptoms in case formulation and care planning. Talk with the patient about the formulation, share any hypotheses you have about the role of trauma and trauma-related symptoms in the formulation, and invite their perceptions and feedback. These are really important conversations. If trauma-related symptoms are interfering with treatment or care in any way, openly discuss this with the client and try and collaborate on finding a way forward. So work together. Remember, this is likely to involve approaching rather than avoiding, and that's really hard for patients if they're accustomed to avoiding, and it can be hard for clinicians. Don't be afraid to ask questions. Always provide a rationale for the questions that you're asking, but I really want to highlight the importance of not assuming that you know. So I've often seen clinicians falling into this trap of they see something as hard for someone that they know has a trauma history, and then they assume that they know why. They assume it's related to the trauma and that they can connect those dots. But when we actually go and ask the question of, can you help me understand why X is hard for you? We actually find out something different. So really important to ask questions. So just want to share some final thoughts. Please do offer hope of recovery to your patients and clients who've experienced trauma and are having trauma-related symptoms. Recovery from trauma is very possible. There are good treatments that are known to work, which, as I said, Jessica will tell us about. This can be really hard. It was hard for me when I started doing this work. We have to resist the urge to avoid and also resist the urge to caretake. So sometimes mental health clinicians can tend to fall into one of those traps of colluding with avoidance or fall into a caretaking role. Instead, we really want to treat patients as capable, encourage life functioning, and build on their strengths. Also want to highlight, you do not need to be an expert in trauma and PTSD to provide good trauma competent care. And then, as I already mentioned, just putting in a plug in for please do refer folks and recommend to them that they receive evidence-based treatments for PTSD if they do have PTSD. And then I wanted to share my email address to invite anyone who has questions that we don't get to answer today to email me, or if anyone's interested in the psychoeducation workbook that we use with patients, I'm also happy to share that via email with anyone. So I will end there.
Great. Thank you so much for your wonderful talk, Catherine. Very informative and validating for some of my clinical practice. So thank you for that.
Great.
Do we have time for a couple questions? Yeah. Okay. I'm just going with the. There was some requests about how to access some of the things you talked about. So I think you answered that already about providing your email.
Yes, please do email me. Happy to respond to emails and happy to share that workbook. As I said, it is written for people with eating disorders, but on my to-do list is to rewrite it so that it's really appropriate for people who might be experiencing any of the mental health problems that we see in people who've experienced trauma.
Wonderful, thank you. Okay, I'm going to get to some of the questions here. Is your approach different when PTSD trauma is intertwined with very high degree of guilt and a sense of responsibility for the situation?
Is the approach different?
Yes.
No, it's not. So like self-blame and guilt about what happened, really like hallmark feature of PTSD. So really getting people to approach what happened, feel their feelings about what happened, let those feelings start to come down, and then people become more open to starting to think through what happened and to start to see things differently. So there's some really good treatments. I'm not going to spoil Jessica's talk. I think she might tell us a little bit more about this in her talk, but happy to come back to it. But yeah, the treatments for PTSD target this in particular.
Okay, can I ask one more question? Could you provide some clinical examples of clinicians going along with patients' avoidance? Any specific examples?
Yeah, great question. So going along with avoidance, so things that we see are in group therapy and people needing to have a certain spot in the room, a certain seat that they sit in. Only wanting to have on an inpatient unit, only wanting to engage with certain nurses, saying I can't have that nurse because that nurse is a man and the person who raped me was a man, so I won't be able to interact with him. These sorts of things, like there's a myriad of things that happen, but these are the kinds of things that we often see in our clinical practice, and that frankly we were getting really stuck. We were getting quite stuck because I think people were thinking that trauma-informed care meant reducing distress. And people really had the belief that in our eating disorder program, people were here for eating disorder treatment. They weren't here to address their trauma. So it wasn't fair for us to ask them to do things that might be hard. And really, when we step back and think about like the things I talked about today, you can't really see when someone has a trauma and an eating disorder and they're intertwined, you can't separate them out. It doesn't make sense. So once we really started to think about things differently, and got a little bit more sophisticated in how we're talking to patients about this. We've managed to get ourselves unstuck and our patients unstuck, which has been really great.
I think I'll have to talk to you a bit more about that. We experienced that as well. So thank you for sharing.
Happy to.
Okay, I think for time's sake, we're going to move on. And we'll have time for more questions at the end for the panel. So thank you very much, Dr. Trache, for your wonderful talk.
Thank you.
Okay, for our second presentation, Ms. Jessica Berto is currently completing her PhD in clinical psychology at Toronto Metropolitan University under the supervision of Dr. Candice Monson. She is a member of the Impact Lab, which focuses on the assessment and treatment of trauma and PTSD. Her primary research interests center on change mechanisms in evidence-based psychotherapies. Her dissertation explores the role of one such change mechanism in cognitive processing therapy for PTSD. We're so pleased to have you here today with us. Please join me in welcoming Jessica Berto for her presentation on evidence-based treatment for PTSD.
Thank you so much. Yeah, so wonderful to be here. Thank you, Dr. Trottier, for kind of starting us off. I think this presentation will be a really nice dovetail to that. Can everybody see my screen? Looking okay? I'm going to take over and walk us through some more specific evidence-based treatments for PTSD. When we look across different clinical guidelines, trauma-focused therapy is recommended as a first-line treatment. Unanimously, there's a recommendation for trauma-focused CBT. So treatments like prolonged exposure or PE, and treatments like cognitive processing therapy or CPT. Several also recommend treatments like eye movement desensitization and reprocessing or EMDR therapy. For today's talk, I decided to really focus on these three treatments. I think based on empirical evidence, it makes sense. I also just wanted to give folks some nice breadth, just kind of get a sense of different PTSD kind of treatments available in the community. My goal is to sort of give us a crash course in the time that we have. So I will be kind of providing a theoretical foundation of all these treatments, right? How do these treatments actually understand PTSD psychopathology? How do they target that psychopathology? Again, echoing that really helpful foundation that Dr. Trottier laid out for us. I'll give us an overview of session content, right? What do these treatments actually look like? And then I'll finish off with just a little bit of empirical evidence, specifically around efficacy and dropout rates. So buckle up, here we go. Our first crash course is going to be about prolonged exposure or PE. So in 1980, PTSD is included as a diagnosis for the first time in the DSM. And at the time, it was conceptualized as an anxiety disorder. So when it came to developing treatments for PTSD in the 80s, kind of that exposure therapy seems like a good bet, right? Given what was already pretty well understood about effectively treating anxiety conditions. So extended to PTSD, this involves folks really kind of confronting any feared or avoided trauma-related stimuli, situations, objects, right, systematically to allow that fear, that negative emotion to kind of habituate and improve their symptoms. So it makes a lot of sense. But as we've learned about, avoidance is very pervasive in PTSD. So not the easiest thing to systematically address all of these moving parts. So FOA and colleagues, the developers of PE, started wondering if there was kind of anything we can do to kind of increase the bang for our buck. They started thinking about exposure to the traumatic memory itself. Their model, which is called the emotional processing theory, suggests that people with PTSD have not emotionally processed the traumatic event. this traumatic event lives in their memory in what they term a fear structure, this tightly linked structure that includes any trauma-related elements, right? So trauma-related stimuli, any trauma-related responses going on, and any meaning that was derived from the trauma. And they suggest that it's this sort of structure and memory that's really driving the pathology, right? Anything resembling these trauma elements in people's environments or their experience is going to kind of activate the structure, drive that escape, that avoidance, right? Keep those emotions really activated and kind of overgeneralized to even pretty innocuous situations. So they proposed that it is essential to really activate this fear structure, this kind of structure in memory, and update these elements, right? Transform this structure to help folks recover from PTSD. So if you can guess, they proposed doing that with exposure. So what does that look like? So if you're a PE clinician, this is delivered individually, usually about 8 to 15 sessions, 90 minutes a session. The start of treatment, folks are really oriented kind of to the treatment, right? The role of avoidance, right? That trauma competent care Dr. Trottier was talking about, really trying to increase buy-in in terms of like why we would want to confront the trauma and trauma-related situations. Very early on, folks are already starting to plan for in vivo exposure. So therapists will support clients in planning how they are going to confront different trauma-related stimuli that they might be avoiding, right? And that's typically done between sessions. So kind of leaving the session, planning to systematically, right, work up to those sorts of exposures to already support that habituation process. From session 3 onwards is when we start that exposure work with the traumatic memory itself. So this is imaginal exposure, asking clients to evoke that memory in session and recount it repeatedly, right? Over and over. This is kind of recounted in a very visceral way, very present tense. And therapists are encouraging clients to just draw on any details, what you can see, what you can smell, right? And repeating particularly anxiety provoking or distressing parts of the memory. These recounts of the memory are actually audio recorded, and folks are asked to listen to those recordings for homework as well. So again, we see that this sort of in vivo and imaginal exposure really form the tenets of PE. Again, the idea being that we're bringing up the memory and we are kind of allowing folks to habituate to any fear or negative emotions, which allows them to then kind of have a different relationship with this memory. And then as a PE therapist, you can kind of extend that emotional processing, right? What are you thinking now? What are you feeling now? What is the meaning of the trauma now that it's less kind of activated and visceral for you? Always looking for opportunities to challenge any kind of tricky beliefs, right? There's still that CBT basis. And yeah, over time, we expect that that kind of distress, that anxiety provoking element of approaching the trauma-related situations comes down and people are able to recover from their PTSD. Okay. Crash course 1 done. I'm going to move on to a second psychological treatment, which is cognitive processing therapy, or CPT, which takes a bit of a different approach. So again, CPT embodies that sort of model that Dr. Trottier was talking about, right? That PTSD fundamentally is a disorder of non-recovery, that there are things that people are engaging in that impede that otherwise natural recovery process from trauma. So of course, one of those things is avoidance, right? That's part of the kind of gig at all times. But another thing is trauma-related beliefs. As a CPT therapist, we are really trying to look for beliefs and cognitions that might be getting in the way of that recovery. So from this perspective, there's a sense that people are constantly trying to categorize and make sense of their world, right? We're getting bombarded with information, and we have a stake in organizing that information. We need to feel like it makes sense. I can predict things, right? I have this sort of control. It helps us just feel kind of at ease. Otherwise, it can feel pretty destabilizing when that information is not integrated or made sense of. You can imagine that when people experience a traumatic event, it can really pull the rug from underneath them, right? All of a sudden, they have to make sense of what was perhaps very shocking, very kind of, unpredicted. And CPT aims to really understand how people are trying to make sense of what happened, right? In other words, if there's a discrepancy between people's kind of beliefs or expectations and this traumatic experience, how are they trying to reconcile those things, right? There's a tension there, and perhaps the way they reconcile these things are kind of driving that pathology. So we look for a couple of ways that people typically do this. The first is folks might actually revisit what happened and really try and make sense of it, right? What was the mistake? Who dropped the ball? I have to explain what happened to me or a loved one. And this is what we would call assimilation, right? They're assimilating somehow the traumatic event with their existing beliefs in service of kind of preserving the sense there was some sort of kind of something I could have predicted. I could have prevented it if I just find what it is. This is where a lot of that kind of blame finding happens, right? So one typical explanation is that's self-blame, right? If only I didn't drink that night, I wouldn't have been assaulted, right? Or it's the US government's fault for kind of harming my fellow soldiers, right? And that kind of drives this sort of cycle of trying to make sense of what happened. Other times people kind of swing the other way, and in trying to reconcile their beliefs and the traumatic experience, their actual belief system is kind of updated, right? They start to take on this very extreme negative quality. Now I think there's actually absolutely no predictability in the world. I have no power. I have no control, right? That would be the only thing that explains how this could have happened. And as Dr. Trottier said, especially for folks who already came in with these negative beliefs and views about themselves and the world, experiencing or re-experiencing a trauma can serve to strengthen those beliefs. So those are sort of the sort of mental gymnastics that we're kind of looking for as CPT therapists. And again, yes, these sort of strategies that people are engaging in preserve their belief system in a certain way and preserve the sense the world does make sense. There is some sort of justice, right, to be found. But it comes at a cost, right? We see that these sort of beliefs really drive what CPT terms as manufactured emotions, right? People get stuck in that guilt, that shame, that displaced anger based on how they're making sense of the trauma. And that actually prevents them from accessing what would be understood as a natural trauma-related emotions, right? So that sense of loss, that grief that needs to be felt, right? Things that we'd expect come after a trauma and absolutely would be part of kind of processing and moving forward. So that is our job as CPT clinicians, right? CPT is a structured therapy. Every session kind of has an important list of agenda items. It can be administered an individual basis, group, and it's typically about 12 sessions. There's some room on both ends. So at that start, right, again, orienting folks to treatment, talking about avoidance and the role of beliefs and emotions. And then having clients actually put together an impact statement for homework. So this document that asks them to outline, how are they making sense of the trauma? What do they understand the cause of the trauma to be? And what are their beliefs about themselves, the world, in different kind of important areas we would expect to be disrupted from trauma, right? Safety, control, right? Things like that. And this serves as a really excellent roadmap for clinicians, right? We start to look for beliefs that might be driving those manufactured emotions, keeping them stuck in this sort of cycle of making sense of what happened to them. And we actually label these beliefs as stuck points in CPT. Over the course of the remainder of treatment, clients are just introduced to several kind of cognitive skills to work with those stuck points, right? Identifying those beliefs and putting those beliefs through the ringer a little bit, right? Is it true that that is what happened that night? Are there things I'm not considering? Does my brain tend to make sense of these things in a certain way, right? And what is other important information that I need to consider? Again, all in service of helping people connect and access these natural emotions that at this point haven't had a chance to actually be felt and processed. And this is all done. There's a big emphasis in CPT on really taking a Socratic stance, right? We're not there to be directive or argumentative. There's this sense that we want clients to become their own cognitive therapists and really learn how to challenge those things. So there's a lot of kind of Socratic questioning and kind of curiosity and openness coming from the therapist. The last thing I want to mention about CPT is there was an important dismantling study in 2012 that compared that protocol of CPT that I just reviewed to a version of CPT that also includes a written trauma account, right? So in other words, having clients also write out a long, detailed account of what happened to them, right? Moment by moment, everything that they saw and felt and thought, and having them kind of reread it repeatedly. So certainly very similar to that sort of exposure component that we were talking about earlier. What was really interesting is the study found that CPT without these written accounts actually was associated with better treatment outcomes, right? People got better faster. The exception was for clients who were really dissociative coming into treatment. If those symptoms were really extreme, then there was something about this added trauma account that helped with their recovery, right? Perhaps putting that memory together in a more kind of grounded way. But I just wanted to highlight it because I think at the time it really threw a wrench into how we were thinking about trauma treatment, right? The sense that exposure and habituation is essential to people getting better. The study kind of suggested that there might be other mechanisms that are helping people process, even if we're not spending time with a detailed account of moment by moment what happened to them. Just checking an eye out. Great. So moving right along into eye movement desensitization and reprocessing, EMDR therapy. So I think for starters, this is a bit of a controversial treatment. I think there are really strong proponents of EMDR. And likewise, I think there are clinicians and researchers who are sort of a little bit skeptical about EMDR. Part of that controversy might actually stem from the way it was developed. The story goes that the developer, Dr. Shapiro, was walking in the park one day and happened to notice that when her eyes kind of followed these leaves, kind of moving side to side in the distance, it actually helped some of these distressing thoughts she was having that day, right? They kind of were alleviated. So she wondered, like, is there something about these lateral eye movements that is supportive in cognitive or emotional processing? She was really struck by this idea. So her team started to really test this, and they started to see these interesting connections between these sort of saccadic eye movements and helping people work through distressing events. Their treatment is based in their model called Adaptive Information Processing, AIP. The idea is that all of us have this adaptive information processing system in our brains that is constantly taking in information and trying to process it in an adaptive, positive way. There's a stake to process this information in line with kind of psychological health and well-being. And they suggest that something kind of dislocates a traumatic memory or distressing experience from this inherent system, right? It's able to circumvent this process somehow. And they propose through EMDR, we want people to kind of get back in touch with the system, put this memory through what is this inherent processing system. And they suggest that eye movements or other forms of kind of bilateral stimulation are going to aid that process. So we'll talk a little bit more about that particular mechanism, but just to give you a snapshot, EMDR is described as a kind of complex integrative psychotherapy, and it's an 8-phase treatment. So there's a lot of moving parts and components that are used to help folks kind of get through this treatment and support processing. Delivered individually for up to 3 months, I believe, and sessions are about 60 to 90 minutes. In the middle phases is where that reprocessing really takes hold. So what happens is we ask clients to evoke that traumatic memory, right? Whatever memory is being targeted. So really kind of bringing it in and kind of in a detailed way, bringing it forward. At the same time, clients are focusing on some sort of bilateral stimulation. So historically, I don't know if you can see my finger, but this might have involved the therapist moving their finger kind of side to side in front of the client's face. So they're asked to kind of focus their attention on both aspects and just let any associations regarding the memory to just come forward, right? Whatever comes up, just kind of let it go through. So the idea is there's something about this dual attention task that is allowing that memory to come forward in new ways, right? It might be less visceral, less kind of negative emotions coming through, new insights, right? And we want to capitalize on that in the context of EMDR. So kind of bringing that forward and then processing forward, trying to help folks integrate that new experience, any new insights that come through, and consolidate kind of those gains as they kind of come back into their day-to-day, right? How can I now think about what happened and what is my relationship with this memory now that I've gone through this processing? So the question is, how would these eye movements or other bilateral kind of stimulation actually support this sort of processing, right? And again, there are several meta-analyses that do suggest that these eye movements do kind of contribute to treatment outcome. And there's lots of different hypotheses. I should also mention, by the way, that, there's also different forms of this. I think nowadays there's like a light bar folks can use. Sometimes there's tactile stimulation, right? Whatever sort of dual task is being implemented. So there's lots of different hypotheses around this. There's a great review that I highlighted on the slide, but just to give you a flavor of one of these hypotheses, there's this sort of sense that with this dual attention task, essentially, it's actually changing people's perception of the traumatic memory, right? It's coming forward to them less vivid, less visceral, less tied to all these sensations and emotions, right? One possible way is that the dual attention task is taxing our working memory, right? There's only so many things we can hold at one time. So that memory is kind of less vivid, less visceral. And as a result, right, as it comes forward in that way, it clears space for kind of new insights, new developments, because it is kind of less potent, so to speak. So there you have it. Really just quick crash course. I wish we can go into more detail, but those are the tenets of these different treatments. I think if I can give just my own 2 cents, right, not being, an expert by any means, I think that often in the literature, right, we see a lot of distinctions between these treatments, right? When in reality, there's probably a lot of similarities. At the end of the day, even if the vehicle through which we're helping folks process might look a little different, there are shared components. We're asking people to bring up that memory and the traumatic event, right? Work with that memory when it's live, activated, right? Malleable, when there's space for new insights, new kind of perspectives, no longer avoiding what happened to them, and essentially clearing space for these emotions that probably have, not been able to come to the surface before. So again, that's just my 2 cents. I know folks feel similarly, but I wanted to kind of end off with that piece before moving quickly into empirical support. Very high level overview, several meta-analyses really kind of supporting the efficacy of these trauma-focused therapies, including PE, CPT, and EMDR. And what we see is across these trauma-focused therapies, the effects are pretty comparable, right? Or there's not evidence to suggest a differential effect. So, you know, take that as you wish, but all of these trauma-focused treatments are really good options potentially. The literature does suggest that these trauma-focused therapies are more efficacious than non-trauma-focused treatments. So those that only focus on like skills and not kind of going back to the trauma are less efficacious. And also that trauma-focused therapies are more efficacious than some pharmacological treatments. I think there's some evidence around some SSRIs, SNRIs, and it seems that the trauma-focused therapies are more efficacious, and that this efficacy seems to be sustained long-term. If we look at follow-up data across these different trauma-focused treatments, seems that people maintain, for the most part, a lot of these gains. So I just wanted to finish up with something I think Dr. Trate was already getting at, right? Sometimes there's this sense of, okay, great, but can people tolerate these treatments, right? Are people running for the hills the second we want to talk about their trauma? And by and large, the vast majority of folks are tolerating these treatments, right? The most recent analysis I saw had a dropout rate around 16%, and that is similar across these trauma-focused treatments, right? When we think about dropout, there's a lot of different factors that can that can contribute to that. And there's actually no conclusive support that the reason people are dropping out is because of that trauma-focused element, right? Some studies have suggested there's slightly less dropout when there's not that trauma-focused treatment, but several have suggested that's not the case, right? So ultimately, I think where I want to leave us is just the sense that there really is strong empirical support for these trauma-focused therapies, and that there is, potentially kind of a clinical duty and ethical duty to consider, good reasons for why we would withhold those sorts of treatments, right? People can tolerate them. We're seeing good effects. And I think the maybe gap that is missing in the literature is just there's such an abundance on efficacy data, but so little when it comes to kind of moderators of treatment and also mechanisms, right? Going back to what I said, I really have this suspicion that there's something going on across all these different forms of trauma-focused treatments that are helping folks get better. And it might be something that's kind of trans-model, trans-theoretical. And I think work in that domain can really help us optimize those treatments. So that is it for me.
Thank you so much, Jessica, for your thoughts and your comprehensive crash courses on evidence-based treatment for PTSD. Wonderful. Thank you so much. I think we have time for one question, then we'll save the rest for the panel at the end. This is from Joe Trainer. Thank you, Jessica. I'm wondering what your thoughts are about length of time needed in doing exposure. How long does each individual exposure actually need to last? I've heard different things about length of time a recording or imagined exposure needs to be for it to be effective. Wondering what the most accurate and what theory is and on why it would need to be a certain length. Okay, that was a lot.
No problem. No, I appreciate that question. I'll do my best to answer it. Admittedly, I'm not a PE therapist. I really come from that kind of cognitive processing camp, full disclosure. From what I understand, typically PE spans like 8 to 15 sessions, just depending on where people are at with how they're habituating, right? So throughout this trauma recounting, they're rating their subjective distress and anxiety, right? What we would want is towards, as we repeat this recounting, that people's subjective anxiety or distress is coming down, right? Maybe it's 10 out of 100 if it started at, 90 out of 100. So I imagine where they're at might kind of influence how the span of treatment and also how lengthy they are. The actual recounting itself, gosh, I I think it also varies. For example, in the manual, I think it says that if you can find these hotspots in the memory, you want to really zero in on that and repeat just that section 6 to 12 times, right? So it's not that every detail has to be recounted, but trying to get a sense of where there's kind of a lot of that charge. So yeah, probably not the most helpful or kind of comprehensive, but hopefully just give us a little bit of a sense of the variability.
Yeah. That was great, Jessica. Thank you so much. We're going to get to some of the questions later on, and we're going to move on to the third presentation so Jessica can answer some questions hopefully later on. Okay, so moving on to our final presentation, but there he is, Dr. Jan Rytev. He is a registered psychologist providing consultation and treatment in clinical and health psychology. Dr. Rytev has practiced psychology for the past 37 years, of which the past 17 years have been as the psychologist at the Cardiovascular Prevention and Rehab Program at UHN, Toronto Rehab, my neighbor. His current practice is in the assessment and treatment of medical patients with anxiety, depression, pain, sleep disorders, and trauma. Dr. Rytev has a diploma in behavioral sleep medicine from the American Psychological Association, is a clinical certified complex trauma professional with the International Psychotraumatology Association, and is a certified EMDR therapist and a consultant in training with the EMDR International Association. And rumor has it that he's written or is in the process of writing a book on this topic of sleep and trauma, which he's going to present for us today. Please join me in welcoming Dr. Jan Rytev.
Well, thank you so much, Martha. I appreciate the kind words. And I really am looking forward to doing this presentation. Let me just find my slides here. And I've titled the presentation Sleep and Trauma. And let's see if I can get this going. Okay. So in some ways, this is really an autobiography of my own development and growth in psychology. So I came to Toronto Rehab 17 years ago, and I'd been used to using interventions to help people sleep. And of course, many of our cardiac patients here had sleep problems. And then as I continued work here, I discovered also many of them have trauma difficulties. And so I think what I want to do is to kind of, first of all, go through some of the objectives. So if we think of this talk as kind of following up on and maybe broadening what Catherine presented on mental health, and we kind of shift the focus from mental health to physical health, and that there are many things that happen in medical work, whether it's surgeries, or other interventions that really disturb the patient. And there's other things that I found really disturb patients, which is when their heart begins to cause them massive problems. They can't breathe. It feels like they have an elephant on their chest. They are struggling to just function. And they have that moment of panic and fear, I'm a goner. And that moment is where the autonomic nervous system just fires off and completely dysregulates what the experience has been, and really locks in for the patient every moment of what is going on in a way that stays with them and kind of haunts them in their recovery. So what I want to cover in this presentation is how we can help these patients, because unlike patients that Catherine was referring to, who may have had an assailant, either rapist or somebody assaulting them, or some other external event, the one thing that's very different in medical patients is that the assailant is your own body. So when your heart begins to stop and you recognize that you can't breathe and you're in dire problems, that autonomic dysregulation is going to to really create a problem that I think can be resolved through trauma therapy. And so what we're going to do in this presentation is just talk about the importance of sleep. That's going to be a very brief, recounting of what is it that sleep does for us. And I like to think of sleep as both the barometer of what your autonomic nervous system is doing for you, as well as a doctor that is helping you heal from whatever has happened to you, whether it's physical or emotional. So it's a given that trauma dysregulates your autonomic system. Many of our cardiac patients and other medical patients do have PTSD as a byproduct of what they've experienced with their physical health. And they may or may not have had problems with mental health prior to that event. The other thing that I've come to understand and that recent reviews of the literature have emphasized is that trauma work itself does not resolve sleep problems. And so I'm putting forward a way of looking at the trauma patient that includes 4 major targets of your work. One is the trauma work, as Jessica reviewed. There's also, for many patients, attachment wounds from early relationship dysfunctions, and those have to be dealt with in the work with the so-called complex PTSD patients. All of our medical patients have some level of body symptoms, and many also have sleep disturbances. So first, a quick review of what is sleep and why should we care in working with our medical and mental health patients. And I reference on the top here a wonderful book by Matthew Walker for any of you to follow up and do some reading, because he really does a good job of marshaling all the evidence. So in terms of restorative sleep, I tell patients that sleep is your body's and your mind's natural doctor. If you're sleeping well, your sleep is actually helping you in recovering and healing, whether you're healing from a physical problem like a broken leg or an emotional problem like an assault. Okay, sleep is important. And we can kind of describe 5 elements that define what we mean by restorative sleep. The first element is that it's consistent, that you go to bed each night at roughly the same time, and you wake up in the morning at roughly the same time. So consistency. The second is that you sleep for 7 hours or more, and that's the recommendation for all adults over 16. A third is that the actual quality of the sleep, which is the intensity of your slow wave sleep time, is appropriate, and that it's helping the brain to recover from whatever has happened in the daytime. And I'll explain some of the functions of slow wave and rapid eye movement sleep in just a second. A fourth element is that you can sustain sleep all the way through the night, that you don't keep waking up every hour or 2. And then finally, and I think this is a very important part of understanding that sleep is not a standalone symptom or issue. It is a part of a rhythm, and you sleep in order to wake up and function, and you function hard so that you can sleep hard. So it's really establishing a rhythm between those two that defines health and well-being. So when you go to sleep at night, your brain actually does not just shift into a sleep mode and stay there all night until the morning. It actually goes through a very interesting and very intricate series of changes in the wave forms of the sleep, where from the active daytime function, it goes into more of an alpha rhythm, then a theta rhythm, and then what's called the delta rhythm, very, very slow waves. And this is called slow wave sleep that you see down here. And then it kind of goes back up through the theta and alpha and up into a rapid eye movement phase. And this is called an ultradian rhythm. It's 90 minutes long, And it's a sign that your brain is using the opportunity. Once you've shut down your input from the world, it's using that opportunity to process information, to regulate your emotions, to fix what's broken in you. All of those things can now begin to happen. And this is the sign that it's doing that really, really well. And you can see these 90-minute cycles continue through to the morning. You can also see that the slow wave parts of sleep are usually in the first 3 hours of sleep. And in the last 3 hours, you have mostly the rapid eye movement or dreaming sleep. So how do these come about? What is it that creates that? So on this next slide, you can see this ultradian rhythm down here. There's the first one, here's the second one, there's a third one, a fourth one, and a fifth one. And this is for a healthy sleeper. And when you look at what the brain is doing once it falls asleep, is it's generating these waves that go from the thalamus to the cortex, cortex to the thalamus. It's like a relay of information. And these are called A1 subtypes. And all of this activity is really helping the brain get into a state of calm. Very important, very essential. And this is what generates that slow wave sleep pattern. And then you'll notice after about 90 minutes or so, you get these dark lines, which represent A2 and A3 subtypes, which are basically A2 relates to movement arousals or activation, and A3 refers to autonomic activity. So both of these mean that your nervous system, the autonomic system, is getting active, and it kind of fires up a little bit. And that's what generates that switch into rapid eye movement sleep. And here's a second cycle like that. And in this case, the activity of the A2 subtype woke the sleeper up. And there's the REM sleep. So that's what a healthy sleep looks like. We'll come back to look at what happens for someone who is experiencing trauma. But what are the functions of the slow wave sleep and the REM sleep? There are many, and I'm just going to list them. You can read about these. This is like a whole hour-long or a day-long presentation in and of itself. So physical restoration, repair of tissue, hugely important. Memory consolidation. Your brain is transferring memories from short-term to long-term memory through the slow wave sleep period. Energy conservation, your metabolic rate, heart rate, blood pressure, breathing, everything slows down so that there can be healing and restoration and recharge. Your immune system rebuilds, and the brain actually clears toxins. These include things like beta amyloids and so forth that build up in the brain during the daytime. They're all cleared up at night during slow wave sleep. And in REM sleep, rapid eye movement sleep, memories are integrated with other long-term memories. So what you learn today gets put in with what you've already known. And it helps in removing the emotions. So the eye movements that happen in REM sleep actually have now been shown to remove the emotional load of memories. So it's very interesting that for something to come into REM sleep needs an emotional load, but then the emotional load is removed from, or that tag of emotion is removed from the memory so it can be put in with other long-term memories. And of course, REM sleep is very critical for brain development. You see in infants, newborns, over 50% of their sleep time is REM time, and it restores brain energy, and it's also critical for making new associations. So that's the crash course on sleep. So trauma, what does trauma do? So the essence of it, and I'm not going to go through, I think Catherine provided a really good review of PTSD and the symptoms and so forth. I work with medical patients, and I look at every patient as what's happening with their autonomic system. How stabilized is it, or how out of control is it? And you can kind of think about it in terms of the system is in control, that the right and left parts of the brain are happy with each other, and you are in what's called a ventral vagal state, where you can take in information, you can engage with people around you, and you have a good sense of well-being. But as there are any kind of acute stressors or any trauma, that you're going to shift from that balanced state to a state of high arousal. You know you're in trouble. When you can't breathe and there's an elephant on your chest, you know this is big, big, big trouble. So this creates this intense arousal. Adrenaline gets dumped into the bloodstream, and that adrenaline itself helps to save the memory of what's going on in the body, that intense feeling of the elephant on your chest, and you're feeling that you can't breathe. All of that is locked into the brain. And if you can't escape that situation, then you go into a kind of a freeze response. And of course, a heart attack is a perfect example of something you can't escape, because you can't outrun it, you can't go anywhere, it's in you. So many patients begin to get into this state of feeling frozen and helpless. So why I want to kind of underline what's going on is I think it has hugely important implications for working with all medical patients. And if you think about the brain as an information processor, that moment to moment, it's taking in information from around it and from within the body. And all of that is aggregated in the brainstem. So this is the central processing unit for the brain. And then it tries to figure out what does it need to do. So it kind of goes with the information up to your limbic system, which is also related to emotions. Autonomic activity is mainly down here in the brainstem. So this is where the fight or flight reactions, the freeze responses are all triggered at this level. But it can trigger emotional responses of different kinds. And then all of that information goes up to the right hemisphere of the brain. That's important to understand. Your right hemisphere processes bodily sensations, emotions, and the broad context that you're in. And then once that's kind of registered and sitting in your right hemisphere, then the right hemisphere and the left hemisphere begin to talk, and you create an understanding of what's happening. Now, with trauma, the big problem is that the intensity of these feelings and reactions actually begin to break that connection with the hemisphere, and that's called dissociation. The person just can't deal with it. It's too much, and so they just block it out. Very important. So in terms of what's happening in the brain, so the left side of the brain is the part that we love the most. It is the part that we can connect with others, we can form sentences, we can talk about what's important to us, we can analyze things. This is the part that all of us feel most proud of. But it's the right side that really runs the show, because it's receiving information first, and it's processing information, locking it into memory, and deciding what's safe and what isn't. So this has an important implication, because body memories are very important in many, many medical situations. And so in some cases, these can be traumatic for the patient. So I gave the example of somebody who's having a cardiac arrest and realizing they can't breathe. But it's not limited to that. There's many kinds of activities that happen within UHN and within other hospital settings that activate that autonomic system and get it to react. And out of that, you can get a situation in which the memories that are being held in the right brain are overload situations. And a great example of this is phantom limb pain. But there are many, many other ways in which our medical patients respond to what's happened to them medically in ways that are trauma related. And the example of phantom limb pain is very excellent because it highlights that this is the case where a soldier may have walked onto a landmine and it blew up one leg. And, you know, the leg is amputated, but afterwards he complains there's still pain in that limb. So that's not coming from the limb outside. It's coming from what the right brain has internalized and locked into its memory circuits. So what is it that these states result in? What is it that patients do, or how do they behave and handle these things? Well, for many, these feelings are overwhelming, can lead to substance abuse, whether that's drugs or alcohol, or it could be prescription medicines that they just can't stop the underlying activation. They can lead to sleep disorders. Whenever your autonomic system is dysregulated, you're going to have sleep disorders. You can have autoimmune conditions across time. A very interesting cardiac condition is Takotsubo, which is basically a heart attack that's triggered by trauma, cancers, etc. So there's many different ways in which trauma can affect us. Now, how is it that trauma can be conceptualized to affect the medical patient? So this is a diagram from a recent review published a few years ago, and I think it captures an important aspect of what I'm trying to convey, which is that the hyperarousal doesn't just affect your emotional self. Yes, you feel terrified, you feel afraid, you may feel angry, guilty, shame, etc. It doesn't just affect your thinking or your physical state of agitation. It can also affect your frontal lobes, it can affect your memory, but because it affects your sleep and those non-REM and REM periods that we need at night to function normally in the daytime, that dysregulation of the sleep in turn then causes problems with memory. Decreased recovery of sleep affects your emotional regulation in the daytime and so forth. So you can see there's kind of a interaction between those two states. So what are the sleep disturbances that emotional and autonomic dysregulation cause? Well, these are published reviews in the last number of years, and they all indicate that of patients with trauma, these are all patients diagnosed with PTSD, 50% or more will have insomnia, 50% or more will have regular nightmares, and up to 50% will have sleep apnea. So you'll recall what I showed you earlier about how a healthy brain pushes the sleep pattern into those slow wave states. And then after a period of time, you get that activation of the autonomic system and leading to REM sleep. And then more of the A1 subtypes pushing you into deep sleep again, and so forth through the night. So this is what a normal sleeper's sleep looks like. This is what an insomniac's sleep looks like. So there's almost an absence of the A1 subtypes for an hour or two, or even longer into the night. And in fact, there's just as many of these arousing subtypes, the A2, A3, which are basically preventing the person. If you look at the hypnogram down here, they're getting no slow wave sleep at all. And they do get into REM sleep eventually, but it's after a series of awakenings, time after time. And then there's a period of REM and so on. But this is not normal sleep. And it's not a normal autonomic system. That's the key idea here. Recent reviews have demonstrated that targeted treatment of sleep disorders in the context of PTSD offers unique and underutilized opportunities to advance clinical care and research. And we need more protocols and better protocols. And targeted sleep-focused interventions can improve sleep symptoms, but not just sleep symptoms, because if you're improving the autonomic dysregulation, you're also improving PTSD symptoms. And a recent review concluded it's long been thought that interventions focusing on trauma itself would eventually reduce disturbed sleep. It doesn't. And so accumulating evidence shows that sleep disorders play a central role both in the development and the maintenance of PTSD, and therefore are an essential target for treatment. So that leads me to talking about what is this treatment going to look like? What is it that we need to target? And I said earlier that there are 4 important targets for treatment with any patient, and some require more work with one or another. Some may not require anything but work with the trauma itself. So it varies, but these all 4 of these areas are critical to trauma, to competent care provided to trauma people. Another recent review suggested that a way to conceptualize this is there has been a trauma of some kind, and that has led to this dysregulation in the autonomic system, which not only increases arousal, daytime hypervigilance, avoidance patterns, but also sleep, nightmares, and apnea. And there is an important role for intervention there. There are tools that are in the public domain that can easily be used by any clinician working with trauma patients. The sleep condition indicator uses the DSM-5 diagnosis of insomnia disorder to determine whether the patient has a significant level of insomnia. The insomnia severity index predates the DSM-5. And then there's the fear of sleep index, which is, I think, particularly helpful in working with insomnia patients with PTSD, because it's not just that they're sleeping at the wrong time. Most of them have an intense fear of sleeping, and it's a fear of loss of control, because what sleep represents is becoming just relaxing and letting go. And in the past, clearly, bad things happened when they let go. So there's other ways that we can screen for these problems. So I'm not going to go into that. What I'd like to spend some time on is a case. So there is a case that we did a webinar on. It's about an hour and a half long. It's on Takotsubo syndrome. It's available at the Cardiac College website. So anyone who's interested can go and find it there. I just want to kind of say a few words about this patient who had a heart attack, and he woke up, or didn't wake up, he in the afternoon when he was working at home, he had a major heart attack. It felt like an elephant on his chest. He couldn't breathe. He was nauseous. He was only 37 years old, so he did not think it was a heart attack. And he lay down and hoped that it would go over. He continued to have those symptoms for 3 days, and finally went to the hospital, was diagnosed, had stents put in, and was given the appropriate treatment for cardiac symptoms. I treated him across 16 sessions in order for him to get back to work, because his heart attack happened in the room in his house where he did his phone calls from for work. And he didn't want to go into that room, let alone to work in it when we first started. So having him approach and understand that he can function and he can work through the dysregulation was a major I guess, goal of our treatment. And the slide just indicates some of the interventions. It's not just trauma work that you're doing. There's many other interventions that need to be happening in order to help the patient regulate themselves in different ways. So with that, my takeaways for the audience. If you happen to be a medical patient, I think it's important to understand that there are both medical and emotional symptoms that many people experience after a major health event. For hospital administrators, I think it's really important to understand that though they're providing medical services, many patients also develop emotional issues because of those. For teams that work in hospital settings with patients. Trauma and sleep interventions, I would say, are essential to help patients get better. And for my medical colleagues, I would say consider trauma as a differential diagnosis when there are complex cases and medically unexplained symptoms. There's almost always some kind of trauma that's gone on behind that. And thank you to the audience. Appreciate the opportunity of speaking on this important topic, and to all our patients who I've had a chance to work with and my colleagues here at Cardiac PM.
Thank you so much, Jan, for your wonderful talk. I think we have time for a couple questions. And they're disappearing. Where did they go?
Uh-oh.
There was one specifically for Jan. Oh, here. What are your thoughts on using mindfulness techniques with those that have PTSD or have experienced trauma, not as a main treatment, but as part of treatment?
Okay, that's a really good question. I think there's literature in the mindfulness kind of broader literature that it can be helpful, but there's a big caveat that when you have somebody just kind of focused inward, there is a possibility that memories, flashbacks, those kinds of things can pop into their awareness. So it can at times result in situations where the person who's trying to meditate is actually re-traumatized or feeling that this is not a safe thing at all for them. So I think if you're going to do meditation, you would do it with the patient in the office or, using Zoom technology, face-to-face, so that they're with somebody who can work with them if some of those situations come up.
Wonderful. Thanks so much. And with that, I'm going to invite the other Dr. Catherine Trache and Jessica Berto to join as well. And please feel free to, if you have anything to add to that. I think we're going to go, I think you've been busy answering a lot of the questions that have been in the Q&A section, because we were worried we weren't going to get to all of them. So thank you so much for doing that. But there were a couple that we just wanted to say out loud because others might be interested in as well. This is a question from Moira Ferguson. How do you address strong affect and dissociative states that arise when people are recounting traumatic events within the context of CPT? So Jessica, I know you've answered that already, but please, if you could share some of your thoughts on that, that'd be great.
Yeah, with pleasure. I think this is a really great question. And I think just wanting to normalize that sense of a clinician of like, well, what am I going to do, right, if this comes up? So a couple of things come to mind. If folks have a tendency to dissociate, I think it would be appropriate to kind of just help ground them, not spending too much time, but just kind of, bringing them in. Okay, can you focus on the room here, right? Acknowledge what's happening, listening to my voice, right? Kind of staying with it. I think it could also be really helpful to kind of anticipate that ahead of time. So during the assessment phase, really getting a sense if people have a tendency to dissociate or kind of numb out. And I typically give a bit of a preamble of like, hey, we're going to approach these emotions and memories for the first time after avoiding for so long. It wouldn't be unexpected that there's that kind of temptation to avoid, or that some of these kind of dissociative kind of tendencies come through. So just kind of getting that on the table out the get. In terms of that second question around how to deal with strong affect that comes up, I think that, especially in the context of CPT, we want to be conceptualizing what emotions are coming out, right? If it's those manufactured emotions, there's this guilt, this shame that is just so painful coming through. We're already thinking about that link to their beliefs, right? What is driving that emotion, right? And we would think about that as kind of keeping them stuck. So looking for opportunities to come back to kind of that cognitive work. I think I wrote like something that can be helpful is just to reflect, like, Like there's been a cost to thinking this way. Like this is such painful emotion that's coming up. Finally, if the strong affect that's coming up is not these manufactured emotions, they're actually these kind of natural trauma-related emotions, right? All of a sudden, after kind of challenging some of that self-blame, kind of feeling that loss, that grief, right? It is painful, right? It might come up really strong. That's okay. What we understand is these natural emotions do run their course. As therapists, it's our kind of job to tolerate that, be there with them, and just give as much space as possible to these experiences that they haven't had a chance to go through. And certainly anecdotally, I can say, like, hang in there. They do run their course, and it is really, I think, rewarding to kind of see that trajectory.
Jan or Catherine, please feel free to add anything.
Well, that was it.
Okay, I would add just one thing, and that is that typically those raw emotions don't bubble up in the first meeting, right? So you have a chance to work with the patient. And I think Jessica underlined that most of these trauma therapies work by establishing safety. You spend 1 or 2 sessions, or even a month or 2 with some patients that are prone to dissociation, in establishing safety, and establishing ways of communicating if the person is with you or if they're moving away from you. So those things then shouldn't be a surprise down the road.
Great. Okay, I think this question is for Jan. Would you recommend polyvagal therapy for alleviation of stress?
Oh, good question. Well, polyvagal therapy is, I know there is a polyvagal theory, and I know there's also some therapists that are now using polyvagal theory to kind of design, as it were, their own trauma treatment. I would say this field is explosive. There's so much going on. There's so many new ways of looking at what's going on in the brain and how to best help the patient regulate these things and approach them in a way that helps them to get over the trauma. So, yeah, there are people that are doing that. I don't know of anyone myself, but the polyvagal theory is kind of a look at what the autonomic system does, and I was alluding to that in terms of the movement from the balanced brain to the hyperactive to the freeze response. So that's very consistent with polyvagal theory.
Great. I think this question has also been already answered behind the scenes, but might be a good one to discuss. Would it be more efficacious to focus on one type of therapy, or would it yield better results with an integrative approach with a combination of different types of therapy? Catherine, I think you typed a response to that if you want to respond. Though.
Yeah, it's a great question. I think people are tempted to integrate therapies and pull together all the good stuff from each of the therapies. We really recommend sticking to one protocol for a number of reasons. One is that that's the way that the treatments have been researched. They haven't been researched as in terms of integrating them. So we really don't know how well they would work if we did integrate them. And then I think we have some worries that they might not work as well. So they might not work as well because it could be confusing to patients to be getting so many interventions and maybe, within each treatment, and interventions that maybe have slightly different underlying models could be confusing. The other thing I think, we're learning in mental health care treatment, sometimes less is more. So we really want to deliver interventions that are potent and really get the most out of those interventions. So I would worry that if we're integrating and pulling in too many things, that then we're probably skimming over some of those interventions rather than really doing a deep dive into them and getting the most out of them. So my recommendation would be not to integrate, but to stick with a protocol. And I think I wrote there too that a good option is to give people choice, to let them know that it's really nice in PTSD, we have multiple treatments that are known to work. So to explain to people what these treatments are and how we think they work, and to see what one fits best with for them. And then also, if people don't respond to one of the treatments, it's nice because we have other options. So If they don't respond to cognitive processing therapy, they may move on to, I had someone who had a partial response to cognitive processing therapy and then referred them on to a couple-based PTSD treatment because I could see that the interpersonal factors were really maintaining the PTSD. So that's more the direction I would recommend taking there.
Great, thank you. Jan, Jessica, do you have anything to add to that?
Well, I think I would add that if you're a clinician in the community, and I'm hoping that there are people in the community also that do watch this video, that I would encourage them to be interested in multiple approaches, because I know just the way I've learned across the last 20 years is by going to different workshops, learning things, and things that I do in a session can come from various things I've learned. So I think if you view the therapist as a learner, a lifelong learner, and we're always interested in finding more ways of working effectively with our patients. And of course, out there in the community, you're not doing research protocols. So you don't have to keep to a structure that you're testing out in the lab. So I would encourage all therapists to really teach themselves more and learn more about ways that they can help their patients with trauma, because it is a very complex issue, and some patients don't respond well to one form of treatment and they respond well to another. So it means more choices available.
Great. And with that, we're at our time. We're approaching 4 o'clock. So a big, huge thank you to Dr. Catherine Trache, Dr. Jan Reitev, and Jessica Bordeaux for sharing their expertise and their time and their work. Wonderful, wonderful presentations. Thank you so much. And thank you again to our wonderful education committee, Leslie, Susan, Marta, and Danielle, and Christian for helping with the behind the scenes. Thank you, Deborah, and thank you for joining us today. Really great presentations. And really great to see so many great questions and so many participants and attendees. Thank you so much. Have a great day.